Chairman Schweikert and Ranking Member Hassan and members of the committee, it's truly a pleasure to testify before the JEC. The Foundation for Research on Equal Opportunity, or FREOP for short, is a nonpartisan think tank dedicated to improving the lives of Americans on the bottom half of the economic ladder using freedom, innovation, and pluralism. I've always felt a kinship with the JEC, as FREOP's very first policy scholar, Scott Winship, served as executive director here a few years back. We all know that American healthcare is costlier than that of other wealthy countries without better outcomes. Many theories have been offered as to why. Almost all of them are wrong. First, let's review the data. Each year, my organization produces the most comprehensive assessment of the performance of U.S. healthcare in comparison to that of 31 other countries with the highest GDP per capita and a population over 5 million. We call it the World Index of Healthcare Innovation, or WIHI. In the 2024 WIHI survey, the U.S. ranked 7th overall, first in science and technology, but dead last in fiscal sustainability. On more detailed measures, we ranked 22nd on disease prevention and last on affordability of health coverage. Some argue that the U.S. has a free market healthcare system, and that is why American healthcare is so expensive. But nearly half of U.S. healthcare spending is government spending. Indeed, on a per capita basis, no country subsidizes healthcare more than we do. In 2022, the U.S. subsidized nearly $7,500 of healthcare per person compared to $3,100 in the other WIHI countries. Furthermore, there are nations with healthcare systems that are more free market oriented than America's, like Switzerland and Ireland, with lower costs and better outcomes than ours. In the WIHI survey, Switzerland and Ireland rank 6th and 1st, respectively, on disease prevention. Others argue that fee-for-service healthcare is the primary culprit of high costs and poor outcomes because, it's said, charging patients this way incentivizes doctors and hospitals to prescribe more services to make more money. But many other advanced nations use fee-for-service payments and spend far less on healthcare, including Canada, Japan, France, and Germany. Indeed, several widely cited studies show that the volume of healthcare utilization in the U.S. is lower than that of other industrialized countries, but that unit prices of healthcare here are far higher. The single biggest driver of high U.S. healthcare costs, the original sin of U.S. healthcare, turns out to be the decision in the mid-20th century to exclude the value of employer-based health insurance from all taxation. The problem is not that Americans experience third-party payment for healthcare services through insurance. That happens all around the world. The problem is that Americans experience third-party payment of insurance, that is to say, third-party payment of third-party payment of healthcare, effectively ninth-party healthcare. On an after-tax basis, for every dollar a worker receives in wages, the same dollar used for employer-sponsored health insurance is worth $1.51. Over 8 decades, this massive tax subsidy has driven American healthcare prices skyward. Workers have no transparency into how rising healthcare prices depress their wages. Employers and insurers have little incentive to control costs or make their workers healthy. And we constantly demand more services be covered by health insurance in a way we would never demand of car insurance or homeowners insurance because of the tax subsidy. We could fix these problems and many others to boot by using the Swiss model as a vision for a freer, healthier, and more fiscally sustainable system. Switzerland has universal coverage, but there are no government insurers. Everyone individually buys their own private sector plan and takes it from job to job, independent of their employers. The Swiss has many similarities to Medicare Advantage and the ACA's insurance marketplaces, but also some useful differences, especially in terms of incentivizing enrollees to be healthier. I'm happy to discuss these during the Q&A session. I appreciate that the hot topic of the moment is what to do about Obamacare. I've been writing since 2010 in great detail why the ACA's flawed design would lead to higher premiums, not lower ones. I'm very sorry to have been proven right. Silver premiums have nearly tripled and deductibles have more than doubled since the law went into effect in 2014. But it's not enough to criticize Obamacare. There is no future for free market health care without a vibrant, affordable market for individually purchased health insurance. The good news is that there are bipartisan ways to reduce Obamacare's underlying premiums before subsidies are taken into account. Obamacare made coverage unaffordable for the young and healthy uninsured, driving them out of the market and raising premiums for all those who remain. We can fix these problems with 5-to-1 age bands, reinsurance, and other tools I describe in my written testimony. We can dramatically enlarge the market for individually purchased health insurance by helping employers offer workers cash to buy their own coverage and by migrating federal employees onto the ACA exchanges. I'm eager to work with any and all members of Congress from both parties to bring these ideas to fruition. Thank you.
Thank you, Mr. Chairman. I know that there's obviously, it's a hot topic around here, and it should, in the sense that Obamacare's been a disaster for working families. In Missouri, premiums are up over 200%. Insurance profits are up over 1,000%. Insurance companies are doing quite well, but working families have found it harder and harder to pay for premiums. Their coverage has become more scarce. And I want to address a couple things and maybe get at some actual policy solutions. So, Mr. Roy, right now, families can apply for coverage without verifying immigration status of the whole family. What fixes would you suggest that could close that loophole?
Senator, as you know, there was a recent GAO report that raised a lot of concerns about all sorts of program integrity in the AC exchanges. That report was specifically about, I think, income verification and ID and social security numbers, but same goes for immigration status, right? So if you have a robust system for program integrity where you're verifying people's social security numbers, that should address immigration status because those two things go together. But also what's really important is that one of the design flaws of the ACA is there's this kind of honor system where you're asked to estimate what your future monthly income is, and then you get a subsidy based on what you think your future monthly income is. It's very hard to then claw that back. There's technically provisions to do that in the law, but it would be much better for ACA subsidies to be based on your previous year's IRS returns rather than some honor system of what you think your future income would be.
What would be, I'm familiar with what the recent report you're referencing, where I think it was like a 97% fraud rate. If you were submitting a fictitious name or a social security number or the same name as somebody else, under the current system, what could be done to address it? This seems like something that you could have broad consensus, I would hope, broad consensus to do.
I mean, in theory, these are the kinds of things that I would have hoped DOJ would have achieved, right? These are things executive branch, program integrity measures, CMS and HHS already have a program integrity division. It doesn't seem to me like it would be that hard. The one complexity is with the ACA is that there's a federal exchange that many states participate in, and then some states run their own exchange, and so maybe there would have to be a slightly different verification process for the states that run their own exchanges versus the federal one. But as an outsider, it seems to me this should be a pretty solvable problem.
Thank you. Or Dr. Clark, I should say. It's the healthcare, I mean, a third-party payer system is sort of ripe with, consumers are kind of removed, obviously, from a lot of the decision-making they would make when they're at a grocery store or making any other economic decision. But as it relates to hospitals who are still by and large paid for utilization as opposed to outcomes, what are some of the incentives that currently exist for maybe overutilization that Congress could address?
Thank you for the question. So speaking from Banner Health's perspective on this, this is why we as a payvider, we own hospitals, we own medical groups, we own insurance plans. We want to take a risk on the overall population, so it takes those, what can be perceived as perverse incentives out of it, right? Years ago, a hospital might be paid more for heads and beds, right? Someone comes to the ER, care is rendered, they get admitted, there's a payment made there. If we're managing a population, and the pilot which we're proposing looks at this, having us be responsible for hitting a cost target for that population is where we want to go, because it doesn't. It's to our benefit to keep them from getting admitted, especially for avoidable conditions such as heart failure, diabetes-related cost, CKD, things that we know upstream primary care and excellent specialty care can prevent. That's better health for the members and the patients, and since the payment is paid on the front end, that helps alleviate in levels of playing field, so we can work as a system to where we don't have to think about those things as much anymore.
I probably don't have time for one more question, Mr. Roy, because I do think that there's a lot of rhetoric on both sides, but trying to actually get to some solutions is important. Competition is obviously going to be a very important aspect of this, of lowering costs, so it'll matter for real people. In your view, why in Obamacare was there a prohibition for physician-owned hospitals? I don't understand that. Do you think that would be helpful? Why does that exist?
Because the American Hospital Association asked for it as a condition of their support for the bill. That's what happened. But the policy argument, the claimed policy argument was that there would be a conflict of interest if there were physicians owning hospitals, that they would refer people to their own hospitals and therefore steer people away from other hospitals. But what in reality has happened with the ban of physician-owned hospitals is the opposite has occurred. The hospitals buy the physician practices and control the referral volume. So that was a terrible mistake, and I would argue it should be repealed.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator. Madam Senator. Ms. Malauulu.
Thank you, Mr. Chairman. Thank you all for being here today. Look, the fact is that since the Affordable Care Act took effect in 2014, the insurance company profits have skyrocketed by more than 230%, while insurers deny as many as 1 out of 3 claims while receiving billions of dollars in taxpayer-funded subsidies. President Obama, the Democrats who sold us this legislation as affordable, it was a bill of goods. Let's be honest about why we're in the situation that we're in today. And at the same time, premiums have gone up 96% since 2014, and they are projected to rise even further because if they don't have a COVID-era enhanced subsidy, that just shows you how unaffordable this really is on its own merit. Now, the truth is, I agree that we need a bipartisan solution to address this issue, and that is why I've introduced legislation with Brian Fitzpatrick and a couple of Democrats, so it's 4 Republicans, 4 Democrats, very bipartisan, that would address this issue to prevent the steep premium hikes for the nearly 24 million Americans who rely on the Affordable Care Act as well, including 80,000 in my district. But we also need to rein in these insurance companies, the insurance brokers, predatory PBMs, if we really want to drive down costs. So our legislation is a short-term solution, but we're here today because we want to pick your brains about what we can do to really fix this issue overall. And it does require innovative solutions. We have ideas like not just embracing and making sure we're covering innovation, but I have legislation on medically tailored meals. We can talk about incentives, and this is really, I think, one of the questions I'd love to hear Mr. Tingle, Mr. Roy, or anybody who wants to chime in on this. How do we incentivize better, healthier lifestyle choices to lower premiums, same way car insurers do it, right? If you take that defensive driving discount, if you have safety features on your vehicle, if you don't get in an accident in 5 years, you have lower premiums. I understand that some insurers are looking at doing this, but you have to ask for it, number one. Maybe we could do the same thing on the health insurance side with gym memberships, wellness programs, if you're a non-smoker. So my first question would be to anybody who would like to answer, Mr. Roy, on that issue.
Sure. So one of the things, I talk about this in my written testimony, so one of the things that the Affordable Care Act does is it actually makes it illegal for insurers to charge a different premium to someone who is healthier relative to sick. So the kinds of things you're talking about with car insurance, where if you're a safer driver and you don't get into accidents, you can get a lower premium. That's illegal in the ACA. The only thing the ACA allows you to do is charge a 50% surcharge if you're a smoker. That's it. One thing that they do in Switzerland that I would love for us to learn from, or a couple things actually. One is they allow for longer-term insurance contracts. So instead of merely having 1 year of insurance, you could buy a 3-year plan or a 5-year plan. And that really incentivizes the insurer to invest more in prevention because they actually reap the rewards in that 3rd, 4th, or 5th year. If you only have 1 year with that customer and you put all this effort into prevention, you may not reap the benefit of if that customer switches plans later on. So what the Swiss allow you to do is they say, okay, you can have a 5-year insurance plan, and if you meet certain benchmarks like lowering your hemoglobin A1C, or you lose weight, or you reduce your blood pressure, then we'll actually refund half the premium. So that's something Switzerland allows that is now illegal under the ACA, and those seem to me like bipartisan reforms that could enable some of the incentives you're talking about.
Anybody else want to comment on that?
If I could just add quickly, I know it's a brilliant question, and the comparison to safe driving programs is quite fascinating, really. Like, incentives do work. I'll just give you one quick example. Our customers get points for the number of steps they take each day. And the point thresholds are 5,000 steps, 10,000 steps, and 15,000 steps. In my written testimony, you'll see a chart that shows the average step counts. Guess what? There's a huge spike between 5,000 and 5,100. another spike between 10,000 and 10,100. People are trying to hit these things to get the reward. So now life insurers are in great position to think long-term about these incentives. Health insurers, I think generally are speaking shorter term. I'm not an expert there, but it's why our industry, I think, can really step up here.
Okay, the senator mentioned vertically integrated insurers with medical practices. I'm very interested in their work in the pharmaceutical space. They're crowding out independent providers and limiting patient choices. Insurer-owned PBMs have also driven up drug prices, reducing competition and increasing costs on the consumers. I guess my question is for Mr. Fiedler. What steps should Congress take to crack down on predatory PBM practices in order to lower prescription drug costs and increase transparency for patients and independent pharmacies?
So I think one of the fundamental challenges we have in the PBM space is that there's just not very much competition. I'm not sure the problem, honestly, is vertical integration per se, and just the fact that there's, 3 PBMs control a very large fraction of the market, and that allows them to extract a large payment for their services. I do think there are opportunities, particularly on the employer side, from a transparency perspective, of helping employers better understand the terms of the contracts they're signing, and hopefully finding ways to sort of, get a better deal on behalf of their employees.
Thank you, Ms. Moore.
Thank you.
Thank you so much, Mr. Chairman, and it is so great to be here in the Joint Economic Committee. It's one of my favorite things, and to hear this prestigious panel. I've really appreciated and learned a lot from all of you. Mr. Tingle, I was very interested in your Vitality program, and it really focuses on the importance of prevention and early detection. Dr. Clark, you too talked about preventive visits at home and having at-home care being available to people with technologies that focus on prevention. Mr. Roy, you really lifted up how people avoid care and their worst outcomes when they don't have access and they don't have adequate health insurance, and it worsens the healthcare outcomes, and prevention is important. I have often complained because I don't think that the Congressional Budget Office scores prevention in a way that enables us to bring some of these innovative ideas to fruition. I appreciate Mr. Roy and Ms. Malatakis really lifting up the limits of Obamacare, where we can't use some actuarial data to provide lower premium costs for younger, healthier people. That being said, I'm curious, Mr. Fiedler, about whether or not you agree with some of our members of this panel who have just blamed the increase in healthcare premiums totally on Obamacare. I think, Mr. Roy, you lifted up something called the original sin of the employer-sponsored healthcare insurance, where we have employer-sponsored healthcare insurance, we have the government doing Medicare, and then this huge gap of millions of people who, through no fault of their own, work for small companies and can't afford health care, and Obamacare brought in 24 million people. So do you agree that these healthcare spikes are just totally due to Obamacare?
I do not. I think one of the things I said and discussed in my written testimony is that if you look at the premiums that we see in the ACA marketplaces, they're comparable to the premiums we see in employer coverage. So these plans are expensive because American healthcare is expensive, and that has a whole variety of causes. But it's just not accurate to argue that these premiums are high because of the ACA. The other thing I would point out is, we've had a pretty remarkable 15-year period where healthcare as a share of GDP, so healthcare as a share of our economy, has barely risen, which is a stark contrast with the decades that came before. I don't think the ACA deserves full credit for that trend. I think there's a lot of things going on. But I think the argument that the ACA has created this explosion in healthcare costs, it's just very difficult to reconcile with the macro trends in healthcare costs that we've seen over the last decade plus.
Our chairman talked about how 31% of Americans have diabetes, which is a very costly disease. I've seen it personally. insulin and dialysis and amputations, and prevention would interrupt this trend. I also would like to see the GLP-1s being funded not for people who just want to be slim on the beach, but people who are morbidly obese, and that would lower. These are some technologies that I think could help. Can you all talk to me about that? Oh, and also, Mr. Fiedler, you talked about the public option and reining in antitrust laws and the public benefit managers. I want to yield some time for you to weigh in on how these reforms might help us.
So on a public option in particular, I think one of the challenges, as I talked about, is that the prices we pay for healthcare are quite high. And one of the interesting comparisons, if you look at what Medicare pays for hospital services, Medicare pays less than half what private insurers typically pay. They pay about for physician care, they pay about 3/4 what private insurers pay. And so I think this does raise the question of, would people who currently get their insurance on the private market be better off if they were enrolled in an insurance product that determined prices for care more similarly to Medicare? I think there are a whole lot of considerations there, but one of the rationales for a public option really is trying to bring down the prices that people pay for care.
Mr. Chairman, unfortunately, my time has lapsed because I, like you, love to talk and to ask questions, but I'll stick around to hear more of the conversation, and I yield back.
Thank you, Ms. This gentlewoman from Florida.
Thank you. Appreciate it. Thank you for holding this important hearing at such a point in time that is incredibly important for all Americans. I am the newest United States Senator, proud to be here, but I didn't come here to do things like we always do them, business as usual. And one of the most disheartening things that I have experienced in the last year is our country is going into debt faster than any other time in history, so we do things as usual. We just found out that there's more fraud built into these subsidies than we ever imagined from our own government watchdogs, so let's do things as usual. I mean, it's insane, the irresponsibility of that approach and our obligations to the American people. And so I appreciate this hearing because I think it's important that all of us learn more and come up with ways to do things better for the people that we represent. And specifically, I want to talk about a report that just came out in terms of the fraud that is in some of these subsidies. Just last week, the Nonpartisan Independent Government Accountability Office issued a bombshell report showing all kinds of egregious fraud, like tens of thousands of dead people receiving subsidies, people claiming more than 365 days worth of benefits in a year, government accepting clearly disqualifying information. And yet, as we meet here, we have people on the other side of the aisle that are continuing to push to nullify a president's rule that was meant to crack down on some of this fraud. The proposal, at least out of the Senate, was to just continue doing things business as usual, keep pushing taxpayer money out the door, even though we know so much of it is going to bad actors, and I refuse to accept that. As a former federal prosecutor, as a former federal attorney general in Florida, I refuse to accept that business as usual is going to cut it for this country's future success. And so I think we need to create something that works just as badly as we need to fix what is currently broken. And I would like to start with you, Mr. Roy, a couple of issues. Let's start with fraud. We saw the GAO's report of this outrageous fraud that plagues the healthcare subsidies, the Obamacare subsidies. And this is on top of the well-established fraud in Medicare, Medicaid, and state-level health programs already, like what's happening in Minnesota. And this is an inflationary force. This drives up costs as well. It makes healthcare more expensive. And I believe that so much of this fraud, and so many people report to me that the people in place right now, both in and out of government, know that this is taking place. And it's ripping our social safety net apart, jeopardizing its future success. What has been the impact of fraud on American health programs, and what can we do to combat it? And do you think, the most troubling thing to me is there's not one person solely responsible for instituting, rooting out fraud, and bettering our structures in place to prevent it? Do you think we should institute something in whatever legislation is proposed to have a healthcare fraud czar?
Welcome to the Senate, ma'am, and thank you for the questions. As you rightly noted, program integrity is a huge problem across all of these federal programs. The fraud rate in Medicare is about 10%. It's estimated to be at least 10%, which is $100 billion a year. In Medicaid, it's somewhere between 10 to 30%, which is another $100+ billion a year. In the ACA, we don't have good numbers, but it's probably also significant, right? So we talked earlier, I think before you came in, about specifically the ACA piece, which is there's two pieces. One, there's the identity verification, which the GAO report mentioned and highlighted. There's also income verification. That's actually a bigger source of fraud in the ACA, where you basically are asked to give supply your estimated future income in the honor system, and then you get a subsidy based on that, as opposed to actual income verification happening retrospectively. So one of the statutory reforms, and this goes to my larger answer to your question, the real issue is structure. You can have a czar that is a program integrity czar, and there are program integrity divisions within HHS already, but the real question is how you design the system is going to lead to more fraud or less fraud. And my argument, and what I try to describe in my written testimony, is that if you have a universal individual market where people are buying health insurance on their own, with their own money, and yes, getting some assistance if they need it for vulnerable populations, with a look back on your retrospective income rather than prospective income, that creates a lot of the design that limits the ability for fraudsters to take advantage of the taxpayer.
Thank you. I see my time has expired. Thank you to all of you for being here today. It's so important, and we appreciate your testimony.
Thank you, Senator. My friend, Mr. Byer. Mr. Chairman, thank you so much for structuring this, and thank you all for coming. I've already learned a great deal. And Mr. Tingle, by the way, gamification, I'm on day 1,199 on Duolingo. It definitely works. So I'm double her, but she's good. So, Mr. Fiedler, many years ago, Mike Pompeo, before he was an important secretary and CIA chief, and I introduced site neutrality legislation on oncology and on outpatient orthopedic surgeon. And we've persisted every year with different partners. You're noticing that half of all physicians now work for hospitals. I know my own father-in-law had this wonderful little private practice, and when he retired, his partner immediately sold it to the hospital. But every time we introduce this legislation, every hospital system in Virginia comes to visit me and says, oh, we're totally dependent on these extra payments. I mean, this is how we pay for uncompensated care. We just can't make it without that. How do I respond to the hospitals that site neutrality actually makes much more sense?
So I think one thing to keep in mind is, one of the arguments I think related to this is hospitals argue that, the patients I'm seeing in the hospital outpatient department are just so much more complex and the cost, and therefore they're just much more costly to treat. So I need the higher level of payments. And I think the evidence we have looking at that is for the types of services that are being targeted in site neutrality reforms, these patients actually aren't meaningfully more complex than the patients that are being seen for the same services in a physician's office. And so I think one of the key arguments here is simply that these payments aren't higher because the costs are higher. The payments are higher because we've had two payment systems that we just failed to line up with one another.
Great. Thank you very much. Mr. Roy, very much appreciated your testimony. And as a small business person who did the health insurance, for 46 years, I'm impressed every time we do major healthcare reform. It seems like all the economists across the political spectrum, left to right, think we should do away with employer-paid health insurance, either tax it or just do away with it. But I also know that the political pushback is enormous. Do you have any suggestions how we move from where we are to where we should be, a la Switzerland?
It's a great question, and I'm a veteran of those political wars, so I know exactly what you're talking about. The thing I described in my testimony was just that. I would love for there to be a standard deduction or a cap on the unlimited exclusion for the ESI. That would be great policy, and I was sad when the Cadillac tax got wiped out. Having said that, I think if we're not going to go back to trying to limit the exclusion, another approach is to create a functioning individual market in which the plans offered in the individual market are so good in terms of affordability and quality. And we've also legalized the ability of employers to fund workers to buy those plans on the individual market. Then people will just, if you give people the choice in your small business, let's say you were able to give, and you are actually now able to give, let's say $5,000 per worker in an HRA and an ICRA plan for that worker to then go shop for plans on the individual market. If those plans were a lot more affordable and a lot higher quality than what you could negotiate as a business owner in a group plan, then people will naturally gravitate to that individual market, even if you don't cap the employer-based exclusion. So I think there are ways to do this through gravitational pull and something that creates positive incentives rather than simply capping the incentives on the employer side.
As long as I'm asking you hard questions, I was also impressed with your notion that the people in FEHB should migrate to the ACA. I represent more federal employees than anybody in America. I think your idea makes enormous sense. Can you tell me how to make that happen?
Yeah, well, this is why you're the elected official and I'm just a guy with a keyboard. But the calculations, it's actually pretty powerful. So one of the problems with the Federal Employee Health Benefits Plan is that the government pays 72% of the premium, whichever plan you choose, effectively. I'm a little bit oversimplifying. And when you combine that with the tax exclusion for employer-sponsored insurance, what that means is if I choose a plan that's $100 more expensive, I, as the employee, only pay $17 of that. And similarly, if I choose a plan that's $100 less expensive, I only get $17 of the savings. So I have no incentive to choose really a cheap plan. But the way the ACA subsidies are structured, and this is modeled after Switzerland actually, is if you choose a plan that's more expensive, you pay the difference. The benchmark plan is covered, but anything above that you pay for. So if you move people to the silver plan in the exchanges and pay 72% of that, I estimate, our organization estimates you would save $10 billion a year. And that could pay for things like reinsurance and other things that would increase the protections for people with pre-existing conditions and poor health status. So you can make the exchanges actually work better for the healthy and the sick through reinsurance and fund that by putting more federal employees on that system, which also then increases the size of the exchanges, creating economies of scale. So to me, it's a win-win-win if we were able to do that.
Mr. Roy, the chairman says with a tight response.
Sorry.
FEHB with my wife, inexpensive. Exchange, I'm 75 years old, very, very expensive. What's your thought on the age rating on insurance?
So similarly here, what we do now is we effectively punish young people through the 3-to-1 age bands. An actuarially fair age band would be 5-to-1. That's what insurers tell us. And and the paradox is the 3-to-1 age band was thought to say, well, this will help older people and hurt younger people, but that's okay. But actually, the older people get hurt too, because when the young people drop out, older people's premiums go up as well. So widening it to a 5-to-1 age band, but preserving the subsidy structure allows us to hold the older individuals harmless, protect their premiums, but also include and incorporate more younger people into the system. And you can age adjust the subsidies if necessary to account for that as well.
Thank you, Mr. Chairman. It's nice to have some senators with fresh energy. I hope they keep it because Senate needs some energy, good energy for sure. I actually kind of agree with some of my colleagues on the other side that the Obamacare wasn't really the only reasons why we have these problems, but it was a big reason for consolidation. I think you covered a few items. One good thing, so-called Cadillac tax, which really should have been limitation instead of tax, was actually repealed on bipartisan basis. The only cost controls we had there, actually was repealed by both parties. So we have this unlimited subsidy goes through tax, by tax system into healthcare. And then you have unlimited spending. Companies are going to not manage their finances as good if they have unlimited deductions. So I think the limited deductions actually help all the COOs and CFOs to do better. Mr. Roy, you know about physician provide-owned hospitals, right? There is a prohibition. Is that correct?
That is correct.
Yes, so provider competition doesn't exist now. Now hospitals own most of the providers and put them in crazy non-competes, and consolidation and oligopolies lead to what? I mean, this is simple economics, lead to huge inflation in price. When you have oligopolies on every market, and I think Mr. Fiedler would kind of defend inside neutrality, but there is nothing there to defend. If you, for the same services, trying to overcharge, overbill, by physician practice, provide the same services, and have an ability to overbill and lie, truly lied to the federal government, $100 billion overbilling and fraud in Medicare that a lot of these hospitals are doing, you know, there is no reason for it except true fraud, but that's a legalized fraud, but because we're allowed to do it. So there is so much legalized fraud in Medicare Advantage and Medicare, in Medicaid that we cannot keep up with. In Obamacare, that government accountability offices keep sending us reports, and as a former auditor, when I read them, I'm like, OMG, any private company, everyone would be in jail, but that's government, you know, so we continue defrauding the taxpayer and bankrupting the country. So there are a lot of prevention in, you know, that pay, you know, for actually bigger money. If you consolidate it, you have ability overcharge, and Obamacare allow this consolidation and reward it for them. And, you know, and a lot of things were not defined, like charity care was not defined very well. You know, it needs to be tied in. We have a lot of so-called non-for-profit, tax-exempt hospitals that are able to make a lot of profits and provide no charity care. And no one even audits them because we don't have rule. Antitrust doesn't apply to them because it's not under jurisdiction. And a lot of very clever people went to Senate and did exemption for residents not to be able to sue hospitals if they abuse them. They put antitrust exemption. So we, as the government, put a lot of laws to actually benefit large cartels, because all healthcare now is so vertically integrated, horizontally consolidated, we have a cartel problem. This is a real reality, and we do a lot of debating here and drama, but in reality, you know, if you have a lot of power and government helps you and protects you, you will try to abuse, you know, the people, and that's what happened. And people not get better healthcare. And we also, the same government is go bankrupt. So everyone is going bankrupt. 1 in 6 Americans insolvent for medical debt. States are going bankrupt Medicaid. Federal government, $38 trillion of debt. I mean, it's insanity. Employers, large employers are struggling. Smaller businesses are struggling. And we're here still debating, do we need to give more subsidies or we have to do something? It's failed, obviously. The market, and we'll reach to the point where some colleagues on the other side, like Bernie Sanders, wanted single payer, taxpayer, and people will get tired, and honestly, people will say enough is enough, I'll take whatever. I think it will be awful for innovation and will be awful for healthcare in our country, but people will get tired. So I think we have to find a bipartisan way to move this issue forward beyond politics and at least allow some arrangements to have more competition. So if you, from Mr. Roy, maybe I'll ask you, you kind of cancel, if, you answer to me a few questions. But if you say, what would be good? Because insurance market, you cannot even have guaranteed renewable product because of Obamacare on the state markets. And if you cannot do it for consumer, then you do the service to consumers. So you have to, Obamacare prohibits you to have these services. What do you think maybe like Association Health Plan and other arrangements we need to do to provide more competition on insurance market and more competition on provider market?
Well, first of all, thank you for all of your courage on this issue of hospital consolidation, both in Congress and in the Indiana State Legislature. You're one of the people who really everyone looks to on this issue. On your question of how do we incentivize healthy behavior for people who are enrolling in the ACA exchanges, one of the things I talk about in my written testimony, and I addressed it earlier today, is the ability to have longer-term insurance contracts. So if you have a 3 or 5 year insurance contract, this is what Switzerland does. You can actually offer, and in Switzerland, you can offer refunds to people who meet certain thresholds like lower weight or lower blood pressure or lower A1C hemoglobin. So those are some things that we could do that would take a statutory change, because right now it's illegal to charge people different premiums based on their health status. So that's something we'd have to fix statutorily. In terms of your point about the broader issue of healthcare costs, there's a lot we can do. Again, this is a topic that can be very broad, but specifically on the issue of hospital competition, I would raise the Hospital Competition Act, which was introduced in the House by then Representative Jim Banks, who's now obviously in the Senate, and it was introduced in the Senate, I believe, by Senator Braun when he was in the Senate, and it's also part of a larger bill called the Fair Care Act. That has a lot of mechanisms to not only address the consolidation that will occur in the future, which is a huge problem, but we also have to address the consolidation that's happened in the past. We have to create incentives for deconsolidation without using the heavy hand of antitrust. And I would argue that the best way to do that is to limit the market power of hospital monopolies and make sure that they can't overcharge consumers.
Thank you, Mr. Chair, as I gab here with my colleague. Mr. Roy, I have to warn you, you have almost nowhere to go but down in my estimation, because I was bouncing with another hearing, and I got as far watching on YouTube as the first half of your presentation. I was thinking, I love this guy, and I'm waiting for the but. So I didn't see the second half. I'm hoping there's no but I just want to warn you that you're. And specifically, I've always maintained that we get, as members of Congress, people who represent some corner of the healthcare industry will come in and assure us that their corner is the purest and best part, and if only we would help them out. And we very rarely get holistic views. And I think the basic holistic question is, what countries spend the most on per capita on healthcare, what spend the least, and what get the best health outcomes? And I think, chime in if you disagree, that mortality amenable to healthcare is about as good a statistic as you can get that kind of sweeps in, adjusts for social determinants of health and what have you. And every time I look at that data, there is no country with lower mortality amenable to healthcare than the Swiss. And they spend about a half as much as we do. The UK spends less, but their outcomes aren't as good. And I got to that point in your hearing, and I was like, this guy's loving the Swiss. Like, love it, like, bring it on. And I guess what I'd love to have you finish, and apologies if you already repeated this before, it's always struck me that the Swiss have, number one, universal coverage. Every country that has better outcomes than we do has universal coverage. But number two, provides choice, which keeps everything disciplined, that you can hop between the systems. I think one of the things we messed up in the ACA, which I wasn't here, so it's not my fault, but not affording the public option to put some choice on some of the systems. And I guess, number one, do you agree with that? But I wanted to just pick at, before you answer, on, in your opening remarks, you'd mentioned that some of the incentives are not necessarily the problem. And it strikes me that when we're providing much higher reimbursement rates for specialty services than we are for preventative care, we're sending a signal to doctors about what to prioritize. And in my head, if we could change just one problem in Medicare, getting reimbursement rates higher for the things with the best long-term benefits would make a difference. And I just comment on that. Try not to let me down, but if you do, it's my fault for missing the second half of your time.
Well, I'll do my best to give you the elevator pitch version, given the chairman has already critiqued me for my long-windedness. Yes, short answer is yes to the Swiss as a model, and they don't have a public option. Let me focus on maybe that element of the question, given all of the topics you raised. What they do instead,
and I mean that only in the sense that, like, we don't have choice. Once you're in the Medicare system, it's hard to swap in, or VA, right, or whatever. So the public option would have afforded choice to keep the other systems more disciplined.
Right. So I'll say two things. One, I think the way Medicare Advantage determines rates is kind of an interesting hybrid model, because fee-for-service is kind of a ceiling for Medicare Advantage plans. If you participate in the Medicare program as a provider, you have to accept the Medicare rate, so that gives Medicare Advantage plans a bit of negotiating leverage with providers in a way that in the employer system they don't have. So that's an interesting model. What the Swiss do, which I think could be something that Congress adopts here, is they have an interesting system where the trade association for the insurers at the state level or the cantonal level can negotiate with the trade association for the hospitals or the drug companies to negotiate the reimbursement schedule. And then there's an arbitrator on top of that. And that allows them to keep prices in check, because if there's a hospital system that's a monopoly or an insurer that's a monopoly, that's basically canceled out by the arbitration mechanism. And that still allows for a market-based system for prices, but addresses the real problem of monopoly power, which is something that in our system we haven't addressed well outside of Medicare.
So with a minute left, I want to pick on that. And just a piece of math, if we could get to the per capita cost of the Swiss, it's $2 trillion a year of savings in consumers' pockets. Like, this is, I think that's a big number. Question either for you or Mr. Fiedler. I come from the energy industry. The energy industry, like the healthcare industry, is and will always be half pregnant with capitalism. There's parts where we want price incentives, there's parts where we don't want price incentives. In the energy industry, the way you made tons of money was by sitting at the point where you could arbitrage the spread between those two. I mean, that's essentially what Enron did. So where should we be most concerned about arbitrage in the healthcare system between the public benefits and the for-profit parts of it, where we can close some of those barn doors?
I'll try to give a very brief answer, which is the amount of arbitrage is massive, and the way you get to the bottom of it systemically is to have more people buy their own insurance rather than having it through another third party purchase it for you. But I'll leave the rest to my colleague.
I'll say the clearest cut arbitrage we're seeing right now is hospitals buying up physician practices so they can relabel them as hospital outpatient departments and get higher payments from Medicare, right? That's just a clear-cut arbitrage opportunity, and there's no rationale for it.
Thank you all. Yield back.
Well, thank you very much. I'm geeking out on the Swiss stuff because I'm half Swiss. My grandparents came from Switzerland, and I'm head of the Swiss caucus, which you're welcome to join at any time, Representative. Okay, so I'll start with you, Dr. Fiedler. You said that increasing competition, there have been talk about monopolies and the like, in the health insurance market could lead to lower prices. Talk about how extending the healthcare tax credits increase or decrease competition in the health insurance market.
So one of the things we know about the tax credits is that they've made the market larger. And I think when the market is larger, it's a more appealing target for more insurers to come into. More of them can justify the fixed costs they need to incur to enter that market. I think probably it's not a coincidence that during the period, as we've seen marketplace enrollment go up, we've seen the number of insurers in the market increase as well.
Okay.
The last thing I'll say about a longer term is it also means we have continuity of the data at minimum over 3 years. Because when someone decides to attribute themselves to our accountable care organization, it's not until about March of that year that we actually start getting their claims data to flow in to drive the analytics, the AI, and everything to say, hey, here's a patient who has high risk for adverse events. If we've had 2 prior years of experience of claims coming in, HIE feeds, lab feeds, all these other things, we've gotten muscle memory knowing who that member is and can make sure that we're keeping close with them and wrapping all those services around them. So the longer 3-year term, I think, is a very important part of how we look at this going forward.
Mr. Roy, how do I make that work?
Well, my favorite idea for liberating healthcare and creating a lot of the incentives that Mr. Chairman, you've been talking about for so long, is to effectively say that for the top decile of people in the Medicare program, in terms of lifetime earnings, that we say, no, you know what, we're not going to ask middle-class taxpayers to subsidize your healthcare cost. Go get your own insurance or get your own healthcare. And 1/10 of the Medicare population is, let's call it 6 million individuals, 6 million seniors. And all of a sudden, you'd have this massive population. 6 million is fairly large because these are older individuals that consume a lot of healthcare. But then you have this ability to rethink how we cover and care for those individuals from the ground up using 21st century technology. So all the things that you've been mentioning, what about wearables? What about artificial intelligence? What about new modalities of care? You'd be completely freed from the way employer-sponsored insurance has worked, the way Medicare has worked, all the things doctors get paid for or not get paid for. You could completely reimagine it from the ground up. And that could lead to a lot of the positive incentives in terms of healthy behavior that you're looking for. Go ahead.
No.
I was going to say, the one last thing I will say on this topic is it's really important to appreciate that prevention doesn't necessarily always lead to lower health costs in the long run, because we all have to die of something. So maybe that individual doesn't have diabetes, but they might get cancer later, or Alzheimer's disease, or bust their hip, right? So mortality is the one certainty, right? So even if you want to have a cheap healthcare system, the best way to do that is for everyone to die of tuberculosis at the age of 30, and I promise you'll have a low-cost healthcare system, but obviously that's not what we're looking for here. So there's a degree to which I want to make sure that we all understand that prevention is good for public health reasons, but sometimes that may also lead to more expenditures.
Yeah.
So that's okay.
And Mr. Roy, whether you remember or not, you and I have actually had part of this conversation because I've always wanted to redefine definition of prevention to be a revolution in the management of chronic conditions. I despise one of the things we've done in U.S. healthcare is we finance your misery. We finance you managing your, the 5% that's 50% of healthcare, instead of also doing those things that are curative. And we're going to come back and talk about the fact we're on the cusp of revolutions of we can cure hemophilia. We're almost on the cusp of some major changes in diabetes, the ability to maybe reintroduce undifferentiated islet cells and some of these things, which would be a revolution of ending the management of misery to the curative of it. Let's do something that's not necessarily Republican or Democrat. There apparently is an agreement that in the next few months, there will be an oral tablet glutide coming, and its price will be $149 a month. We've been trying to do some back-of-the-napkin math of what that would mean to my state's Medicaid system. If the majority of my state's Medicaid system is technically, its BMI is obese, what would happen at the end of 2 years if we helped our brothers and sisters get healthier? And look, diabetes, obesity, they're complex. We've learned there's autoimmune issues, there's more to it. But let's actually take a look at, I'm going to go with you, Dr. Clark, and then let's see who else is daring enough to comment on this. We've already done our economic study showing that obesity is 9.1 trillion additional healthcare spend in America over 10 years, making it the single most expensive thing in our society. If the glutides are about to become functionally 20%, 18% of what they were 1 year ago in price, what does that do to change the future utilization of those with multi-chronic conditions? And where this partially comes from is we have the Milken study from a few years ago actually, saying 47% of US healthcare is associated with obesity. We know 33% of US healthcare spend is just diabetes. Are we on the cusp of a moral solution that could dramatically change the price of healthcare?
I think yes. The literature shows that just if you isolate diabetes and show that you're controlling the blood pressure of those patients, you're improving their A1C control, you're putting them on statins, just that alone has significant impact on some of those things I spoke about earlier. It delays blindness, progression of chronic kidney disease, avoidable hospitalizations, all those things, dialysis, right? So if we just focus on that alone, the benefit that it could have, that could be amazing. We continue to learn in the literature, and it's hard to keep up because there's so much that comes out about this class of meds, other protective benefits it has too in other areas. So if drugs like that are out there with a favorable side effect profile where we can go out with them at scale, could have a wonderful impact on the US healthcare system. And the other thing too, to one of my concerns, we don't have enough primary care doctors to take care of our folks in Arizona. We did a survey on our network some time ago and found that a very high percentage of them are going to be over 65 very soon. And so, again, if we're not having to worry about the complications of obesity and diabetes quite as much because it's better managed through these new innovations, that demand on the PCP can somewhat be relieved as well. So I think there's lots of benefits there.
Anyone else dare to go close to this? Mr. Roy.
I have 4 bullet points for you on this topic. The first is that the reason we don't have a physician shortage. We have a primary care physician shortage. The reason for that is this thing called the RUC committee in Medicare, which basically pays specialists more than primary care physicians due to, basically who has political power within the AMA. So that's something that Congress can fix. That's number one. Number two, there are statutes, the Stark statute and the anti-kickback statute, that basically make it very hard for technology to be interoperable in a way that that people can monetize and entrepreneurs and innovators can monetize. So we have to revisit Stark and anti-kickback laws and modernize them so that technology can be more interactive within various healthcare providers. The third thing is AI. So right now, if you have a primary care shortage and you don't want to fix RUC, the other thing we can do is use AI to enable nurses and other physician extenders to practice to the top of their licenses. And let's also reform the licensing laws that unfairly restrict, with a guild mentality, what nurses and extenders can do. So that can help address some of the shortage. And the final thing I'll mention is that when it comes to drug development, one of the real mismatches that we have is that drug companies can basically charge $1 million per patient per year if they develop a drug for a super rare disease, but they can't for diabetes because it's a more competitive market. On the flip side, the clinical trials for a rare disease are much cheaper than for a large disease like diabetes, because the FDA will make you do a trial with 50,000 patients and 5 years of outcomes data that costs you literally $2 billion to run. And so what do pharmaceutical and biotech companies say? They say, well, I don't want to develop a new diabetes drug or a diabetes treatment because I'll have to spend $2 billion developing, and if I'm wrong at the end, I'm out of luck. Whereas if I develop a drug for a super rare disease that only 50 people in America has, I can make the same amount of money, but my upfront risk is lower. So that's something we have to revisit if we want to actually create an innovative ecosystem that's addressing common chronic diseases like diabetes and heart disease.
All right. Lightning round. Anyone else first on obesity willing to comment? Then, Mr. Clark, are you familiar with concepts like Civica RX? At the co-op.
No, can you give me some background on them?
Mr. Roy, you're familiar with my fixation on, we play this game here. PBMs are evil, PBMs are fine. Drug companies are evil, drug companies are fine. Retail pharmacies are fine, they're evil. And I want to argue that we're on the cusp of a revolution happening right now, where I see major pharmaceutical manufacturers selling directly to consumers. I see Medicare, Medicaid systems, hospital systems, insurers coming together and making their own. And that's what Civica RX is. They're making 3 types of generic insulin that is cheaper than the subsidized price we produce from the federal government, where we subsidize. But I've even had a presentation a summer ago of a company that's doing 3D printing of drugs. So at your hospital system, here's your generics. You put in your orders a week or 2 ahead, and you just print them right there. Mr. Roy, you're familiar with some of these concepts. Are we on the cusp where we're having the wrong debate because we're debating last decade's siloed systems, and is technology about to change everything from the way we do health management with technology to the way we actually even access our pharmaceuticals?
Here's the biggest problem on the drug side. The biggest problem on the drug side is that we have a completely different statute governing generic competition for what are called small molecule drugs, old-fashioned drugs that you can synthesize in a chemistry lab, and a completely different statute to regulate off-patent competition for biologic molecules that are engineered and manufactured in living cells. That's Title VII of the Affordable Care Act, which is called the Biologics Price Competition and Innovation Act of 2009. The pharmaceutical industry basically put all sorts of subtle kind of time bombs in that bill that basically make it a lot harder to develop generic biologics, we now call them biosimilars, that would then drive down the price of those drugs when they go off patent. So as a result, we're not seeing cheap generic biologics in the same way that the Hatch-Waxman Act on the small molecule drug side allows us to have commodity pricing when a drug goes off patent. And that's a huge win for public health. When Lipitor goes off patent, all of a sudden, cheaper than this bottle of water, everyone can have basically free cholesterol-lowering drugs. That's a huge win for public health. We're not doing that on the biologic side, and the consequence of that is today, 54% of spending in the U.S. on prescription drugs is for biologic drugs that represent less than 4% of prescriptions. 91% of prescriptions are for generic drugs, and then 9% of prescriptions are for branded drugs, and of those 9%, actually a very small percentage, really less than 1%, drive nearly half of all drug spending. And that's because Congress made it hard for us to develop generic competitors to those drugs.
I think I hear a piece of legislation somewhere in there.
Absolutely.
Anyone else have some other thing, Mr. Tingle, and then we're going to move to shutting down.
Yeah, I would just, first of all, thank you for your passion on these topics. But I would not overlook, there's amazing stuff coming, the power and potential of regenerative medicine, all kinds of things. But we have things right in our hands now. You just talked about GLP-1s. We have early cancer, multi-cancer early detection tests. And we all, private and public folks, need to be working to get these into the hands of the people that are going to benefit them. Because a few years ago, these things were unthinkable. Now we have them. They're amazing tools.
I want to thank all of you for giving us as much time as you have. Do be prepared. I can already see a couple of the team here have all sorts of questions for you. You've all been actually remarkably intellectually forthcoming, and it's appreciated. And with that, this hearing is adjourned.